Diet quality, overall good food, dietary patterns are what's crucial for health, independent of weight of the population or independent of weight of the person. So it's a pleasure to be here, and I want to talk a little bit about how we might achieve behavior change at scale. And so I think the first thing we all know is that we face a global nutrition crisis. It's truly a nutrition crisis that's affecting every aspect of the globe. We've talked a lot about health, and we think about malnutrition, heart disease, stroke, obesity, diabetes. It's clear this is the single leading cause of poor health on the planet. We've talked about sustainability and the environment. This is the single leading cause of environmental catastrophe on the planet, from land to oceans to water use to climate change gases. But I think what we don't talk enough about is all of the economic consequences of this. This is devastating healthcare systems in developed countries, and this will soon devastate healthcare systems in developing countries. This is the single biggest threat to having affordable healthcare and access on the planet. This is also probably the biggest growing threat for government budgets. And I think we have to explain that this is an economic catastrophe that's coming down the pike that's entirely preventable. This is also a major issue for national security. I haven't heard that mentioned at all. Much of nutrition was birthed in national security. So the RDAs, the recommended dietary allowances that drive all of modern nutrition policy, were born in 1941 in the United States under the National Nutrition Conference for Defense, under the order of President Franklin Delano Roosevelt, to prepare the population for war. The school lunch program, the United States school lunch program, one of the major programs of the United States, started in 1945 under congressional order because military recruits were malnourished and couldn't serve in World War II. So this is a national security crisis for almost every country in the world. This is an economic crisis. This is a healthcare crisis. And also, of course, for disparities, for inequities among wealthy and poor countries. Now, the public gets this. I've been in this field and doing research for about 20 years, and the public across the world gets this in a way that they really have never before. There's an uneasy feeling. Everyone kind of knows the food system is broken, but they're also very confused, and they're unsure where to turn for accurate information, and they have nutrition whiplash, turning their head one way or the other, and that's problematic for business trying to produce food that meets the fad of the day. But this is an opportunity. If we can harness this passion, this energy, this attention, we can have really meaningful change in the next decade. So what I want to talk about is how I think we need to get there. And I think the most fundamental thing we have to do is we have to be sure that we're intersecting science and policy. If we put together effective policies, but we have the wrong targets, that's not going to get us very far. We have front-of-pack labels that have total fat on the list. We have black box labels that have total fat on the list, right? We've proven scientifically that total fat is not a very useful target scientifically for health for any reason, yet it's still driving policy as one example. So we need to really be sure that we're marrying the science and the policy. And so I want to talk a little bit about the science, and I think 3 lessons that we've learned that we have to remember when we think about the policies and programs and strategies for addressing this nutrition crisis. So first, I think the modern science lesson number 1 is this is more than about, of course, malnutrition because of chronic diseases. But when it comes to chronic diseases, this is more than about lipids and obesity. Everyone talks about malnutrition and obesity as though obesity is the manifestation of the chronic disease epidemic. Obesity is one minor pathway by which nutrition affects chronic diseases. Cholesterol levels are one minor pathway. So in the 1970s and 1980s, thinking about chronic disease, we thought about cholesterol, and so that led to low-fat diet the focus, because we had sort of that monovision. Now we have the monovision of obesity, and people are just talking about calories as that's the only thing we need to think about. Diet quality, overall good food, dietary patterns are what's crucial for health, independent of weight of the population or independent of weight of the person. So we really have to remember that it's about more than obesity. Lesson number 2, it's not about reductionist nutrient approaches. Reductionist nutrient approaches work great if you have specific nutrient deficiencies, and much of the world still does. but more of the world is suffering from chronic disease, and chronic disease is really about foods. And malnutrition, which is what's causing chronic diseases, malnutrition, bad food, is about the absence of healthy food. So it's not about just reducing single nutrients, and we have to get rid of nutrient X and nutrient Y, and we have to have targets for reducing these isolated nutrients, or we have to increase nutrient X or nutrient Y. It's about eating healthy foods, and people have talked about that. And I think the science strongly supports that. And so you have to kind of think about the foods that we need to focus on. There's a category of foods that are incredibly good for us and that we need to be increasing more in the food supply. Governments and businesses should be focusing, their primary focus for the next decade is getting more of these foods in the food supply. And what's really interesting about the top of the list is, other than fish, which has omega-3s, and yogurt, which is probably good for its probiotics, all of the other foods have something in common. They're foods that give rise to life. They're foods that sprout life: beans, seeds, nuts, fruits. These are the kinds of foods that our bodies need. So these are the best buy policies that I think we should be focusing on. And of course, I don't have time to go into all of them, but I'd like to see, similar to the Framework Convention on Tobacco Control, I'd like to see a Framework Convention on Healthier Food Systems. And these are the policies that we need to institute. Consumers need to be educated to bring this along, but at the end of the day, educating consumers isn't going to change the food system. We have to change it with science-based policies: taxes, subsidies, policies in schools, policies in work sites, policies in healthcare systems, quality standards, and labeling. And I'm happy to share some references about these things, policies, if people are interested. So I want to talk a little bit about big food. People talk about big food like it's big tobacco. Is that analogy correct? So, of course, the food industry has used many of the same tactics over time that tobacco has used: denial, deception, deceptive advertising, marketing to children and disadvantaged groups, influencing politicians, lobbying. Many of the tactics have been similar. But I don't think the analogy is correct, because with tobacco, it's a fight to the death. There's only one product, there's only a handful of companies, and it's a fight to the death. With food, there's thousands of companies, there's thousands of products, and almost every food company that I've interacted with would be delighted to sell healthier, more sustainable food if they could make a profit and consumers would buy it. So at the end of the day, we need the food industry to be on our side. We need to be, of course, vigilant and be sure that we beware of tactics that have been used in the past, but we need food companies on our side. So I think a better analogy than tobacco is cars. This is a graph of deaths per mile driven in the United States in blue from 1925 to 1995. Per million vehicle miles traveled, deaths from car accidents went down 90% in the last century in the United States, and this was true in much of the developed world. How did this happen? How did we have this incredible public health success with cars? How did we make cars safer? Did we do it by putting an automobile fax panel on the car that told the consumer about the automobile and the safety features? Did we do it just through consumer education and through talking to people and through blogs and trying to get people to understand about car safety? No, of course not. We did it through a multi-component approach that addressed the driver, the car, the road, and the culture. And I would say of these four things that we did, the driver was the minor component. I don't think drivers today are much different than drivers in 1950 or 1960. Really what changes the car, dramatic changes to the car, some of them mandatory, some of them driven by consumers, some of them driven by innovation, dramatic changes to the roads, and dramatic changes to the culture, especially around drunk driving. This is the roadmap for food. We do have to address the consumer, but it's going to have a relatively minor effect on our food system. Really what we have to do is address the product, and that means the product from farms to retailers to restaurants to food manufacturers, through carrots, through sticks if necessary. We need to make sure the products are safe. We need to address the environment, not the road, but the cafeterias, the grocery stores, the farmers markets, the availability of food in some of the poorer areas of the world. We need to address the environment. And we need to address the culture, especially the culture around eating unhealthy food. And this was a story I mentioned that in Gamlistan, there's a life-size statue marketing to kids of a little hot dog figure. And I said, this shouldn't be culturally okay to market to children something that we know is explicitly unsafe for them, right? It shouldn't be something we should market for them. There's healthy treats that kids should eat: dark chocolate, a little bit of ice cream, that's fine. But there's really no reason to have hot dogs in the food supply. And so I want to end with the story of John Snow, which I think is a really important story for us to consider. John Snow from the United Kingdom in 1854 was a physician trying to combat the cholera epidemic. And when he was approaching this epidemic, the cholera bacteria had not been isolated. Nobody knew for sure what caused cholera. He drew a map, and this is his map from 1854, of all of the cases of cholera that were happening in the city. And he noticed that they all clustered on Broad Street, and there was a water pump in the center of Broad Street. And when you look, there were some other water pumps further away and some houses near those water pumps. And when he asked those families, they said, oh, we send our kids to the water pump on Broad Street. We think it has better water. So armed only with this map, he went to the public health officials and he said, we have a cholera epidemic. And the public health officials said, okay, yes, we know. And he said, I think it's coming from this water pump. They said, what should we do? He said, well, there's a wooden handle on the pump. Take the wooden handle off the pump so people can no longer use the pump. To their great credit, the public health officials did it. They took the wooden handle off the pump, and the cholera epidemic abated. So that was, to their great credit. Now imagine instead if John Snow, a physician, had said, well, we need to understand, the risk factors for cholera. We need to study populations, follow forward people in time, and understand the predictors of who's going to the well and who's not and who's at risk, and use education and target education and try to get people to understand the risks. Right? That would have been beneficial. That would have helped somewhat. He said we need better medical schools. We need better healthcare systems. We need healthcare access. We need insurance. We need primary care physicians. We need, community workers to treat the people better. That's important. That would have helped. We need a pharmaceutical industry to create better drugs for cholera. And then people aren't compliant, so we need nurses to call patients to be sure they're taking their drugs. And we need these little blister packs that say Monday, Tuesday, Wednesday, Thursday, so people remember when to take their pills, right? We need ambulance systems. We need to study genetics. Let's do genetics in everybody. It's really got to be about the genes. We know it's really in the genes, and epigenetics. If he had done all of these things, he would have had some effect on the cholera epidemic. All of those things have scientific merit. But how much at the end of the day, how much of cholera would he have prevented? 20%? 30%? So while that story, obviously is, I'm being a little bit funny with that approach, that's exactly the approach we're taking right now to address diet-related diseases around the world. We're building this unbelievably complex system of physicians and doctors and ambulance systems and education and all of these things, rather than addressing the core driver of poor health in the world, which is the food system. The food system here is the well, and we need to go and take the handle off the pump. Thank you very much.